Today we'll do a VSD quiz. So it's get ready with your paper, pen, and your answers. So this is more in the format of kind of question and answer, some images and answers. They simple and some not so simple. Okay, so let's get started with the first question. I hope you all had your copy. So first question is, what is the incidence of a VSD? What is the percentage of babies born who will have a VSD? This is Morton Adams' figure. So, well, 1% have some kind of congenital heart disease, right? So the incidence of VSD is around 2.5 per 1,000 live births. So that actually makes it the most common lesion seen in CHD if you exclude a bicuspid aortic valve. Okay. Next question. If a parent has a VSD, is the offspring at increased risk of having a VSD? So if a mother or a father has a VSD, is the child at increased risk? If they come to you for counseling and they say, I have a VSD, if I get pregnant, what is the chance that my baby will have a VSD? Is there an increased risk? Yes or no? Yes, okay, one answer is yes. And that is the right answer. There is a somewhat increased risk. So in 2.9% of offspring, so generally if you have one child with heart disease, your next chance is about 2 to 3% of having a child. If the parent has a CHD, about 3% chance that the child will have something, usually a VSD, though the offspring may not have a VSD, they may have something else that's going on. Okay, next question. Which newborns are VSDs more common in? First question. In which newborns are VSDs more common in? Which kind of newborns you can say? So everyone newly born, but which newborns are they more common in? And next question is, which VSD is most common? Membranous, muscular? Okay, so you think VSDs are more common in full term is one answer. Okay, which VSD do you think is most common? Membranous, muscular, inlet, subpulmonic, subarterial? So answers. Does everyone agree which newborn the VSD is more common in? Any other answers for that question? And the answer really is they are more common in preterm babies and low birth weight babies. Because if you think about it, preterm babies, they haven't had the time yet for the wall to fully form, for all the pieces of the septum to come together. So more common in preterm babies and low birth weight babies, and those you can give it some time to see if they become smaller. Now, the most common, yes, VSD would be muscular. When you talk about an uncomplicated heart, that means a heart in which the VSD is the only CHD, so muscular VSD. But when you take complicated hearts, which means like tetralogy of Fallot, truncus, and you combine all that together, then membranous type of VSDs is obviously the most common one. But isolated VSD, most common would be the muscular one. Okay? All clear on that one? We'll move on to the next question. I see only Prakash answering, so I need everyone to have their coffee and wake up. Left ventricular to right atrial jets are seen in which part specifically of the interventricular septum? LV to RA jets. So AV septal, so you're saying it's in the inlet septum. AV septal is inlet. Any other answer? Specifically, which part of the ventricular septum? So everyone's saying atrioventricular. Okay. Now let me just show you the anatomy of the heart. If you look, we always say, right, that the tricuspid valve is apically displaced, right? So membranous is actually the right answer for this question. So let me just show you this. You know, we say here, so this is the tricuspid valve. This one I'm doing in blue. So you see it, and this is the mitral. So the tricuspid valve is apically displaced compared to the mitral, right? So in between the left ventricle, which is here, and the right atrium, which is here, you see this septum line, this one. This is the membranous septum. And because of the apical displacement of tricuspid valve, there's a little gap between the tricuspid and the mitral here, where the LV abuts with the RA. And this is where you see your LV to RA jet, right here. Okay. Now, inlet septum is actually here. This is inlet, right, where the AV valve. So it will be inferior to the tricuspid valve. Okay. And that's where your typical AV canal or inlet VSDs are. Okay. So the answer to LV to RA jet are seen in which part of the septum? The answer is in the membranous septum. All clear with why? Based on this diagram, look at that arrow A. Okay. So we'll move on to the next question. What is the natural history of VSDs? So what is the chance, if you see a baby at birth, roughly, what is the chance of a VSD closing? Rough percentages. How many percent die in the first year? What is the rough chance of a VSD closing if you see it right at birth? Okay, so 80% by 8 years, that's a pretty high number. You know, now one of the natural history issues is that about 10% will die in the first year because of heart failure, respiratory infections, and so on. Okay, now spontaneous closure is quite uncommon in large VSDs. Now, if you have a moderate or small defect, 30 to 40% will close spontaneously by 3 to 5 years, which is why we wait with moderate VSDs till 3 to 5 years to see if they get smaller. Okay, so in general, if you see decrease in size of VSD, if you have a large VSD, would be around 25 to 30%. Quite unusual for 80% of them to close off. So if you have a moderate VSD at birth, about 40-50% will become small or closed, and those don't require any treatment. Large ones, about 25% may become smaller enough that you don't have to intervene. So it's not that high, and not it's kind of, you can say, if you roughly remember 40-50%, that's about okay. Okay, next question. What determines the amount of left to right shunt in a VSD? What is the determining factor for left to right shunt? Okay, so one answer is PVR, second answer is size. So in which VSDs does PVR determine the amount of left to right? PA pressure, by the way, is not the right answer. After load, yes, because if you have increased after load, you could have left to right. But the PA pressure does not determine the amount of left to right shunt, right? So up to the point where RV and LV pressures are equal, so up, that means small VSDs or moderate VSDs, size of the shunt will be dictated by the size of the hole, right? When the pressures are equal, that means when it's a large defect and you have severe pulmonary hypertension, then pulmonary vascular resistance is going to determine how much left to right shunting you have. The lower the PVR, the more the shunt. The higher the PVR, the less the shunt. Okay, so I think the answer, what determines the amount of left to right shunt, would be size in smaller holes, pulmonary resistance in larger holes, and yes, you are right, you can add to that afterload if you have coarctation or a severe aortic stenosis, some distal alveolar obstruction, you'll obviously have more left to right shunting in addition. But PA pressure per se, pulmonary artery pressure, will not determine the amount of shunting. It will only determine that, it will tell you that the VSD is large and the lung pressures are high. Okay, all clear on that? Okay, next question. What murmurs do you get in a small VSD, moderate VSD, large VSD? So just put them in that order when you answer it. In small, in moderate. So, okay, pansystolic murmur in small. What about moderate? Small and moderate, both will have pansystolic. What about large? Systolic ejection and MDM. Can you ever get a short systolic murmur in a VSD? Okay, so in a large you're going to get ejection systolic. Okay, so that's right. In a small you're going to get a hollow systolic murmur. Remember that in very small, like what we call these closing muscular VSDs, you can sometimes get a short systolic, because when it's very small, in systole the muscle kind of squeezes in and you don't get that pansystolic variety. So if you have a VSD and it's a very short systolic with a normal P2, it's probably a muscular site that's closing. Now, moderate VSDs also, yes, you have a hollow systolic murmur because it's a restrictive VSD. But remember, you can get an MDM if there's an increased flow across the mitral valve. So always listen for a MDM murmur. In a large VSD, you get no hollow systolic murmurs, you get a mid-diastolic rumble from increased flow, and you may have a systolic ejection murmur, a flow murmur across the pulmonary valve. And if you don't have that flow murmur, you start worrying that the pulmonary resistance is very high. So in a large VSD, presence of a flow murmur is a good sign and suggests that PVR is low and the flow is able to get across that pulmonary valve. Okay, all clear on this? We'll move to the next question. When does a large VSD present? At what age? First question. And when can it present earlier? In what situations can a large, so let me get the first question. When does a large VSD present? Okay, so 6 to 8 weeks, that's right. And the reason it's 6 to 8 weeks is because that's when you have physiologic anemia, plus the media of the arterioles is thinned out. When can it present earlier than 6 weeks? Yes, preterm is a right answer. Anything else you can think of? When it can present earlier? And what does high altitude do? When you're up in the mountain, do you have more of a left to right shunt or less of a left to right shunt? Okay, so that's right. If you have LVOT, it can present earlier. So when you're up in the mountains, you have increased PVR and later presentation. Okay, so those are all right answers. Typically, VSDs will present at 4 to 6 weeks, but they can present earlier when you have anemia. Remember anemia, so always look for anemia. If you have prematurity, if you have added respiratory infections, and if you have undiagnosed additional cardiac defects. If you have a VSD in a term baby presenting at 1 week, it's quite unusual, right? So you need to be looking, that's right, you need to look for associated lesions. Does he have AS? Is there a coarctation? Is there some kind of left heart obstruction that has been missed that is increasing the left to right shunt and making this child present with symptoms earlier than 4 to 6 weeks? That's right. Okay. Now, high altitude CHF is less common, right, because the pulmonary resistance is higher because of the hypoxia. And these kids can sometimes, when they come down to the plains, they may present with heart failure. So it's important to take history of where do they live when you're looking at their presentation. Okay, all clear on this? We'll move on to the next question. VSD. What is large? What is moderate? What is small? What do you use to define it? How do you differentiate large from moderate from small? So large has equal pressures, okay, so moderate, okay, that's one way you can look at pressure. Any other methods to define pressure apart from pressure? Okay, you can compare it to size of aorta. Yes, in moderate LALV it will be dilated, so that does not define whether it's large or moderate or small, right? Because large can also have LALV dilated. So the methods that you can use, what about QPQS? None of you have mentioned QPQS. That's right. So QPQS, what is QPQS in a small VSD versus a moderate VSD? What is the QPQS difference between those two versus a large? Okay, so 1.5. You know, it's funny because the National Committee guidelines actually says 2. I have always thought it's 1.5, but if you check our National Committee guidelines, they put it as 2 as the difference between the two. So, in a large VSD, right, the definitions are this, that either the VSD is the same size of the aortic orifice or larger, right ventricular systolic pressure is equal to left ventricular, and QPQS is going to be dependent on your pulmonary vascular resistance. In a moderate, there is some restriction. So RV systolic pressure will be less than LV systolic pressure. Now it could be that RV systolic pressure is 2/3 or 1/4 or 1/3. It is basically less than LV systolic pressure. And as per National Committee guidelines, PPQ is greater than 2. So you guys need to check this because my learning from my fellowship days was the cutoff was 1.5. But I think if you give both answers, you're probably okay. And small would be where our right ventricular systolic pressure is definitely normal. See, in a moderate VSD, you could either have elevated PA pressure, like your PA may be 55 or 60 or 65 with an aortic of 90, or your PA may be 25, but you have left heart dilation, so it's still moderate. That means your QPQS is more than 2. So in a small, you will have normal RV systolic pressures and a QPQS less than 1.5 to 2. Let me ask you guys, in your books, is it 1.5 or is it 2? I can send you all the National Committee guidelines that were published in IP in the Indian Journal. There they've mentioned 2 as the cutoff. So what does the latest Morrison Adams say? Is it 1.5 or 2? Just check that. So a small would have definitely normal PA pressure and a low QPQS, less than 1.5 typically. Okay. So now once you've defined these, this is your definition. Now I know you were talking about chamber dilation and so on. Remember that will not differentiate large from moderate because in both of them you'll have some amount of chamber dilation. So what will differentiate the two would be pressure. If VSD is restrictive, it will be moderate. If non-restrictive, it will be large. Okay. So next question, going with this is, when you have a shunt, right? You define that it's a VSD. Your key questions are: what is the type of shunt? What are the associated lesions? What's your diagnosis? If you have severe pulmonary hypertension, is this patient still operable? If you have a restrictive shunt, is this shunt small or is this shunt moderate? So the first thing you would use is to clinically evaluate the patient. To say, okay, I want to put him into category of large or moderate or small. So you're going to ask him for a history of weight gain, respiratory infections, how he's doing otherwise, right? And on exam, you're going to look whether he's failing to thrive or he's gaining weight, does he have retractions or not, his precordial activity, his S3, is his P2 loud or soft, does he have a flow murmur, does he have an MDM, what kind of murmur, right? So let's do the first clinical scenario. We commonly see this, case 1. Baby who has failure to thrive, he's tachypnic, he has an active precordium, he has a loud second heart sound, loud P2, he has a 1/6 systolic ejection murmur. What does he have? Yes, and the answer is a large VSD. So he's going to have a large VSD with increased QP, right? That means a large VSD with low PVR and heart failure symptoms. Okay, that's good. Case 2, he's asymptomatic, he's gaining weight, he has a quiet precordium, he has a normal P2, he has a 2/6 holosystolic murmur at his base. What do you think this patient has? Yes, so the answer is this. Why do you say innocent murmur? Holosystolic would not be innocent, right? Because innocent would typically be your stilled, it would be a systolic ejection murmur. So, so holosystolic, you would still be thinking of a VSD. Now, the answer, guys, is not small and it's not moderate. The answer is it could be small, it could be moderate. So remember, clinically, when you have a holosystolic murmur, even in an asymptomatic, it's not that all moderate VSDs have symptoms. You may have a lot of moderate VSDs that are asymptomatic. So when you've got an asymptomatic child with a holosystolic murmur, you and a normal P2, you're thinking it's small or it's moderate, right? How are you going to differentiate these two? We will get to, right? So your answer would be small or moderate. I need a little more of some tests, right? So now let's go over some of the tests you would do. You would ask for an ECG, you would ask for an X-ray, you would ask for an echo. So you're suspecting a VSD, you know he has a VSD, and this is his ECG. What size do you think is the VSD? Okay, so you said small, right? Because this is a normal ECG. There's no LV volume load, so it's definitely not large. It's most likely a small VSD. That's right. Okay, what size is this VSD you think? So what size? You've got right axis deviation, okay, worrisome. I'm telling you it's a VSD and you've got right axis. very worrisome. Look at V1, he has an upright T in V1 suggesting RVH. He has Stark-Schwarzschild phenomenon, look at V4, right? He's got both LV and RV forces and right axis deviation. That's right. So this is going to be a large VSD. He's got biventricular hypertrophy, so certainly this would fall in the category of large. Now let's say you want to determine, okay, it's a large VSD. Do you think this patient is operable based on his ECG? Is there any feature in here that tells you, well, you know what, but I still think he's operable? I'm going to, of course, look at his echo and so on, but just by the ECG. There's no, okay, but now look at the Q waves, guys. In lead 3, you've got Q waves. So you've got not gotten all the leads, I buy that, but you have some Q waves. So then there's some Q things that there could be chances of operability. And he doesn't have, you're right, he doesn't have in V5, V6, but then he's got also this kind of RS there, but he has in V3. So look for Q waves in V5, V6. If there are no Q waves, it goes with inoperability. If you see Q waves all over, it suggests volume overload and operability. Now, what about this? This patient has a VSD. What type of VSD do you think he has? So always look at your AVF, right? If you have a negative in AVF, then it's a superior axis, and you're going to be thinking of a inlet type of VSD. So you can see from this that just looking at your ECG is quite helpful in quite a few things in a VSD. What about this? This is a known case of a VSD. What do you think is happening to the patient? What do you think is going on? It's got right axis deviation, right? We have a pure R in V1. It doesn't have any Q waves in V5 and V6, right? So you'd be worried that this patient was developing Eisenmenger. You can't know for sure, but it's very worrisome when you get right axis deviation, RVH, that this patient has gone in for Eisenmenger. Okay, that's right. Now, X-ray is the next test you would ask for, right, to differentiate small, moderate, and large. And you essentially need to look at plethora or absence of plethora and measure the cardiac size. This is how you look at your cardiothoracic ratio. You take the maximum out point here, CR, and then the maximum on the left border, L. Those two should be less than your total diameter of the chest, right? So in order to say whether it's cardiomegaly or not. Now, if you have a large VSD and you see this X-ray, what do you think about his shunt? Is it left to right or right to left, and is he operable or not? So you're going to immediately say, right, he's got increased QP, so he's operable, he's got cardiomegaly, he's got plethora, right? On the other hand, you see this X-ray in a patient with a large VSD. What do you think? And look at this here. That's it. Dilated and prominent pulmonary artery. Right? He's got normal heart size, and he's got no plethora, and he's actually got, look here, there's a cutoff. You see this cutoff? He's got pruning, right? The NPA is dilated, no cardiomegaly, no plethora, and pruning. So this patient probably has Eisenmenger syndrome. So again, your X-ray helps you differentiate the two. Now, let's move on to echo. When you look at echo, you look obviously at the VSD anatomy, the direction of the shunt, the gradient, the LALD dilation, and pulmonary venous flow. These are the 5 things you need to look on in any echo of a VSD. Where is the VSD? What is the size of the VSD? What is the type of shunt? What is the gradient across the shunt? Is the left heart dilated? Is the pulmonary venous flow return increased or not? And of course, other associated lesions. So look at this tracing here. What is the pulmonary artery pressure here? Okay, look here, guys. I think, let me show you this. This is 4 meters per second, right? So it's somewhere here, right? So 4 meters per second, so about 64, definitely over 64 is your gradient. So not systemic, It's normal PA pressures likely, right? So what type of VSD do you think it would be when you've got a high gradient across the VSD? What kind of VSD is it going to be? Either small or moderate, right? You don't you can all you can say is if normal PA pressures this VSD is either small or moderate, right? You can't comment why, Dr. Shada. You can't comment on small or moderate based on this. You can just say it's small or moderate. I have to see whether there's left heart dilation or not to decide, right? Now, let me ask you the question on top. In a large VSD, which has no gradient, okay, you've got a large VSD, there's no gradient, so you apply your PR very carefully, and the PR gradient is 38. What is the pulmonary artery pressure? Systemic, but PR is 38. Definitely, lock किया जाए, पक्का? Yes, the answer is it's still systemic. And so there's no value. Okay, now I got a half systemic. So that was a trick question, guys. Remember, in a large VSD, if there's no gradient across the VSD, this means LV pressure is transmitted to RV pressure. So RV pressure is systemic. If there is no pulmonary stenosis, RV pressure is transmitted to PA, and PA pressure is systemic. Therefore, PR is of no value in a large VSD. And I put this point in because I see a lot of reports saying large VSD with no gradient, PR gets 38, normal PA pressure, or half systemic PA pressure. Remember, physiologically, it's not possible. So if you have a large VSD, you have an LV here, and you have an RV here, and you've got a VSD here, right? So if your LV pressure is 100, right, then when you have a large VSD which is non-restrictive, your RV pressure will be what? What will your RV pressure be? Right? It has to be 100. There's no other way. So RV also has to be 100. PA also has to be 100. There will be severe pulmonary hypertension. So once you have a large VSD, forget about the PR. No point sitting, doctoring it, trying to correlate it. You know that this patient has systemic PA pressure. Okay, all clear on that? PR is of value if you have something like a VSD with double chambered RV. So say your VSD is, distal to the RV muscle. So you want to see what is the RV pressure here and what is the RV pressure there. PR has some value. So of course, if you have PS and you want to collaborate with your pulmonary valve, or if you have a VSD gradient that you're not Dopplering very well, then you can use your PR. But in general, in VSDs, once you have good gradients across it, you don't need to putter around with the PR too much, because especially in your trivial or mild, you will underestimate the PR jet. Okay, all clear on this question? So we'll move on to the next one. This is a short axis view, okay, of your LV. The area above is your RV, and then that's your LV. Which muscular VSDs are seen here? So the first one, arrow on the left, which VSD? Sorry, did it disappear? Okay, which one is the one on the left? No, left of the screen. Yes, left of the screen. Posterior. The one in the middle is what? Okay, so the one on the left is posterior, one in the middle is what? Mid, and the one on the right is what? So what is this VSD? Yeah. Let me see here. All agree on that? So that is not inlet, by the way, huh? Why do you say inlet? See, in a short axis view, remember your AV valve is somewhere this side. Your pulmonary valve is somewhere this side, okay? So this one, this side one, and this is a very important view not to miss, and that's why I put this in. You all know how to pick up membranous VSDs and so on. But this short axis of your muscular section is very good for picking up posterior, mid, and this would be anterior VSDs. So this one here is generally where your pulmonary, if you remember, your pulmonary valve will be somewhere here if you pick. So this shows you anterior muscular. The other way you see, how else can you pick up anterior muscular VSDs? In which view on echo? Anterior muscular VSDs. Which view on echo? The subcostal is one, right? Subcostal sagittal. The other is a long axis tipping up. Long axis tipping up to pulmonary artery, you will see anterior muscular VSDs. Posterior muscular VSDs, on the other hand, yes, you look in your four-chamber view at the index. You can also in your long axis skip down, towards the tricuspid valve, but posterior muscular can be missed. Most commonly in your ICU, missed VSD is going to be a posterior muscular. So always look at the short axis view and look in this region. Mid again, you're going to pick up. You'll pick it up in your four-chamber, in your long axis. It's not, you don't miss it that easily. But posterior ones and anterior ones, don't forget in every view, short axis, before you start looking at aortic valve and pulmonary arteries, skip down and put color flow, turn your Nyquist scale down, put color flow all across this muscular septum to pick up posterior, mid, and anterior VSD. Just put this in your head there. Posterior, mid, anterior. Okay? All clear on that? We'll move on to the next question. Small versus moderate. We've been going on discussing how does one know before an echo. What test would you want before an echo to differentiate small versus moderate? One test. I give you one test before an echo. Which one? We said clinically they'll both have holosystolic, right? One test, which one would you pick? X-ray. So your X-ray will help you differentiate these two. If you have a normal sized heart, it's going to be a small VSD. If you have LV dilation or LA dilation, as you can see here, this is going to be a moderate VSD. So that's right, X-ray is the one way to differentiate small from moderate even before you do an echo. And on echo, you're going to look for left heart dilation. If there's left heart dilation, it's moderate. LALV normal, then it's small. Let me ask you, how do you know for sure LA is normal size? What measurement do you want? To say that this is small and LALV are normal, what measurement would you like to take? You can take the LVID, right, and you can compare it with normal. Look at the LA-AO ratio. That's the right answer. Look at the left atrium to aortic ratio, and it should be roughly the same. Then you know that the left heart is not dilated. Okay, we'll move on to the next question. Angio views for VSD. What views do you use? Now you take, say, the patient with a cath lab for operability. What view do you use to profile a membranous VSD? Membranous VSD, long axial oblique. Okay. So actually, long axial oblique is a combination of left anterior oblique 70 and cranial 20. Okay. Muscular, mid and apical muscular, which view? Let's go in order, guys, so we don't get confused. Muscular, which one would you do? Mid and apical. So again, long axial oblique is the right answer for that. Anterior muscular, which view? Anterior muscular. One answer is right, anterior oblique. Okay, you could do lateral, very difficult to see because you'll have the RV coming in there. So the right answer, if you really want to see, is RAO. Right anterior oblique, very good for anterior muscular VSD. Inlet and posterior muscular, which one? Okay, all agree on that. Hepatoclavicular, which is 40 LAO and 40 cranial. Subpulmonary VSD, which one? Or supracrystal or subarterial or doubly committed, which view? Anyone? Okay, RAO, two answers. Any other answers? And the answer is RAO. That's the right answer. Remember? Okay, now see, the thing with lateral is you don't get a very good profiling of the septum on that view. So it's better to use an RAO view for these things. So for anterior muscular, so anything that you're looking anteriorly. So remember, the subpulmonary is quite anterior. So use RAO views for that. Muscular, mid and apical, your long axial oblique is very good. If you see this angio that's right here, it profiles the whole septum up to the apex very well. Okay, I won't use lateral too much, guys, for most of these views for the VSD. Okay, question. What is the diagnosis here? This is an echo. I hope you can all see it. Long axis view, short axis view. Short axis view. Okay, doubly committed. You think the cusp is in there? So, look at that cusp, how it's sitting inside the VSD, right? So this is A. This is A. Now, which cusp do you think it is? Yes, it's the right cusp, right? So this is a doubly committed or subarterial or suprafiscal or conal or infundibular or subpulmonary. There are many names for it. You pick what you like and use it, VSD. And the incidence is 30%, they say, in the east in terms of this VSD. So very high incidence, as we know, in far East Asia. Okay. Now, what is the mechanism of cusp prolapse? You all saw another cusp prolapse. What is the mechanism of cusp prolapse? Why does it happen? Any theories? Okay, one theory is Venturi. So one of the theories is Venturi, but the other is that there is lack of support of the sinus of Valsalva and annulus because it's so high up. There's no infundibular septal. That's right. Second is the Venturi effect. Third is, could there be a structural defect in the base of the sinus itself, embryologically? So these are the mechanisms of cusp prolapse. Now, let me ask you, what is the incidence of aortic regurgitation in VSD? And I'm not just talking about subpulmonic. In all VSD, say you have a baby with a VSD, obviously that means membranous or subpulmonic because muscular is nowhere near the aortic valve. What do you tell the family? You say, I'm following you up, I'm following you up, I'm following you up because your baby may develop AR. What is the incidence of aortic regurgitation? So the answer is yes. So there are two answers given here, and the answer is really about 5%. Okay. So what I typically tell parents in the OPD is they're following you up every year or two because there's a 5% chance of aortic regurgitation developing. So before it becomes significant, we're going to look for it. Now, once AR develops, once cusp prolapse happens and AR develops, what is the natural history? How quickly does it progress from mild to severe? Over months, over 2-3 years, over 5-8 years? What do you think? Once it develops. Okay, that was a good educated guess. 2 to 3 years, but actually it's a very slow process. Okay. Now, once it appears, it will gradually increase and become severe. In 8 to 10 years. So it's a slow process, though some can progress more rapidly. So you're not going to wait till it becomes severe and the valve gets totally damaged. Now remember that the incidence of cusp prolapse is actually you can have it both in perimembranous as well as in subpulmonic. So in the Western world where their incidence is more or less, they're more membranous, you've got cusp prolapse even in that. So it's not just that subpulmonic gets cusp prolapse, even membranous VSDs can. It is rare before the age of 2 years, typically after the age of 2. Okay. Now, there was a study done in Indian Heart Journal in 1990 looking at Indian patients with VSD and cusp prolapse. Out of 362 patients, 10% had AR, and that was in the membranous, 84% of them, supracystal or subpulmonary, 16%. Omnis cusp, of course, was right coronary cusp. And they found again no relation between severity of AR and the location of the VSD. Okay, so we always think of subpulmonary with AR, but remember that membranous can just as well have coronary cusp prolapse and aortic regurgitation. So which leads me to the question of how do you deal with the VSD and the AR in the OR? Once you diagnose that this patient has AR, what do you do in the operating room to the aortic valve? So you're going to close the VSD, we all agree. What do you do with the aortic valve? Let us say it is mild AR, what do you do with the aortic valve? Okay, if it is mild AR will resolve maybe. If it is severe AR, what do you do? Or moderate AR? So if it is small AR, you only close the VSD. Moderate AR, you can repair it. Severe AR, you may have to replace it, right? So if it's trivial AR, just VSD closure, mild VSD closure, moderate plus minus valve repair, very moderate severe to severe, you have to replace if you can't repair. And remember that sometimes the edge is retracted, thickened, or bicuspid, and you can't repair it, and you've got to be prepared to replace when you go in. So our goal is to not get to this moderate severe. It's to pick it up when it's trivial or mild and just close the VSD. Okay? Now, next question. Do all subpulmonic VSDs need closure? And I ask this, you say yes. Anyone else? Everyone says yes. Is there any subpulmonic VSD that you would not close? Yes, one says right chronic prolapse or AR we would close. But let us say there's no RCC prolapse, small subpulmonic, no cusp prolapse, no AR. Would you close it? So the answer is all subpulmonic VSDs do not need closure, and I'm going to argue with you on this. And I say this because there are a lot of cardiologists who believe that all subpulmonic VSDs need to be closed because they will develop AR. I just showed you data showing that in the Western world, both membranous and subpulmonic VSDs can develop AR, right? Almost similar incidence. So it's not that the diagnosis of a subpulmonic VSD means you need to close it, because even a perimembranous VSD can develop AR, but we are not recommending closure of all small VSDs. So why are we not applying that same logic to a subpulmonic VSD? Is that making sense? So I'll show you some data. This is data that came actually out of Taiwan. They followed 214 patients for 8.6 years, plus minus 5.2, and of that, 73% developed cusp prolapse. Okay, and out of those who developed cusp prolapse, the majority of them developed aortic regurgitation. And if you look at this slide, this thing here about prolapse and AR, as the years went on, 1 year, 5 year, 10 year, 15 years, the incidence of prolapse kept increasing from 8%, 30% to 83% finally developed prolapse, and out of that 64% developed AR. Now all patients with prolapse they found had a defect size equal to or greater than 5 millimeters. Okay, so the smaller subpulmonic VSD did not necessarily develop cusp prolapse and did not necessarily develop AR. So the closure of a subpulmonic VSD depends just like on a perimembranous VSD. If you've got an asymptomatic patient with a small defect, with no left heart volume load, with no cusp prolapse, with no AR, he can be followed just like you follow a perimembranous VSD. If you have a moderate VSD or cusp prolapse or AR, yes, you're going to close it. You're going to use the same criteria that you use in other kids. The only difference is if this is a larger subpulmonic, moderate, let us say 5 or 6 or 7 millimeters, in perimembranous sometimes we wait. We wait till they're 3 or 4 because it may get smaller. Subpulmonic is only going to get smaller by the cusp going into it. So in those kind of VSDs, you don't want to wait too long. You close it earlier. 6 months, 1 year, 1.5 years. So in moderate defect, you have a higher, you can say, you close it much earlier than you would with a perimembranous. But in small subpulmonic, with no cusp prolapse, no AR, follow it up. SB prophylaxis if you want. AHA guidelines, they don't give SB prophylaxis. India was still giving SB prophylaxis, but you can certainly follow it up. If they ever develop cusp prolapse and AR, happily close it. If they don't develop cusp prolapse and AR, happily follow it. Is that clear? I can send you some of the literature on this because this is something I get patients these days who have been to 4 different centers and have 4 different opinions and are so confused. So I actually send them the papers on it, showing that if you've got a small defect, your chance of developing cusp prolapse and AR is quite low and you can be safely followed. The only caveat is you need to make sure that the small, when you're saying small, it's not small because the cusp has gone into it. You really need to look on echo and make sure that there's no cusp that's gone into it, and that's why it's looking small. Okay, all clear? That was a long soliloquy. So we shall go on to the next question, which is timing of closure of VSD. What is the timing of closure of a large VSD? What is the outer limit that you would reach? What do you mean by ASAP? Would you close at 2 weeks? Would you close at 3 weeks? Would you close at 1 month? 3 months, 6 months? Okay. So the outer limit, when is the maximum you would reach? And the answer is 6 months. Okay. The maximum you would reach with a large VSD is 6 months. However, if you have a large VSD which has uncontrolled heart failure, you've given digoxin, you've given Lasix, you've given enalapril, you treated respiratory infection, you corrected his anemia, and he still got intractable heart failure, just not able to feed, not gaining weight, close it off. But let's say you have a large VSD, he's gaining weight, he's feeding, but of course he has severe pulmonary hypertension. You can wait 3 to 6, maximum 6 months. Remember, even if he's asymptomatic, especially if he's asymptomatic, close him off by 6 months because there is a small percentage of kids who will develop irreversible pulmonary vascular disease even before 1 year of age. Okay, so 6 months, but failing to thrive, not gaining weight, in spite of medical management, you can close at 2 to 3 months, okay, as long as it meets those indications. Okay, now next question, and I seem to have put the answer in. Timing of closure of moderate VSD. Well, let me ask you that. When would you close in moderate VSD? At what age? Moderate VSD, what age? 2 to 3 years. Would you ever close it earlier? Would you ever close it at 1 year or 9 months? Would you close a moderate VSD earlier? 1 year, 9 months, if symptoms are significant. That's right. So this is I've taken from the National Committee guidelines. Basically, they have put between 1 to 2 years. Earlier, if there's an episode of life-threatening lower respiratory tract infection, or if there's failure to thrive. But other opinions, if they're asymptomatic, especially membranous or muscular VSDs, you can wait 2 to 5 years because there is a chance they can become smaller in the first few years of life. And as long as you bring the LV volume load back to normal by 4 5 years, you have no long-lasting issues with it. One exception would be a subpulmonic. If it's moderate, you may not want to wait till 4 5 years because at some point it's going to develop cusp prolapse. If it's moderate, not if it's small. So if it's over 5 mm, those you may want to close by 1 or 2 years. Okay, but or AV canal types obviously, but muscular and membranous where there's a chance of the muscle tissue growing or septal aneurysm developing, it's okay to wait 2 to 5 years as long as they are asymptomatic. Okay, so when would you close a small VSD? When would you close a small VSD? You would wait, never. Okay, never say never. That's one thing I've learned in life. Forget about in cardiology. Never say never because the minute you say never, it's going to happen, right? You would follow up, but what are the indications? Are there any indications to close a small VSD? There are some, right? Why are you following up? You're looking for those indications, right? Otherwise, if they're never going to close, then why even bother to follow them up? So the indications are, okay, and this is again, you all need to read the National Committee guidelines. One is prolapse and AR, right? Or a small VSD with more than one episode of infective endocarditis. So the reason you're following VSD, small VSDs, is you're looking for cusp prolapse, you're looking for AR, you're looking for double chambered right ventricle, and you're asking history for endocarditis. Now, if you have a small subpulmonic VSD, any AR, you're going to close it. Small subpulmonic VSD, cusp prolapse, and no AR. Okay, now that one becomes controversial. Small subpulmonic VSD, cusp prolapse, no AR. Some people close, some people don't close. But if you close it, it's quite okay. Some people will wait till mild AR develops. But frankly, once, yes, the guidelines are it is better to close it once there is cusp prolapse. Small membranous VSD with cusp prolapse, again with any cusp prolapse essentially is an indication to close. Cusp prolapse with AR indication to close, or more than one episode of infective endocarditis. Right. These IAP guidelines are actually the same as the National Committee guidelines published in IAP. So if you all don't have it, email me or I'll put it on the portal for the guidelines. The ones on VSD are a little confusing. Even though I helped draft them, I don't know, we came out with a really confusing document. But I think simplest thing to remember is yes, more than one episode of endocarditis, any cusp prolapse with AR or without AR, plan to close it. Okay, we'll move on to pulmonary artery banding. Are there any indications in today's day and age in 2012 for pulmonary artery banding in a VSD situation? If yes, what are those indications? Okay, yes. So what are the indications? Okay, Swiss cheese is one answer. Anything else you can think of? Multiple, okay, large Swiss, multiple, okay. So that's right. Multiple Swiss cheese is a class 1 indication. I think all would agree. If you can't get all the VSDs, you can ban. Very large VSD, almost single ventricle, class 2A indication. Again, this is National Committee guideline. Low weight, class 2A indication. A lot of centers will be able to close. If the center doesn't have ability and characteristics, that could be. And associated comorbidity like chest infections, they're not able to come off the ventilator, not able to, that's again a class 2B. So the only class 1 indication is really your multiple Swiss cheese septum. Okay, but you need to know these other 2A and 2B indications. Okay, can we use a device to close a small VSD? Okay, the answer question should have been, should we use a device to close a small VSD? Yes, carefully. Okay, can use but not needed is the right answer. Okay, so I put this in because you know, as cardiologists, now that we have this lovely device and you don't have to put a star on the chest, it's very tempting to go close all the small VSDs. But it's very important first to decide to close or not to close. You're going to close VSDs which are moderate, which have LALV volume load. Small VSDs, we're not going to close if there's no left heart volume load and there's no collapse, no AR, no history of endocarditis. So first you use your same indication. Should I close or not? What age should I close? Same indication. Then you decide, okay, should I use surgery? Should I use device? You don't say, oh, this is deviceable, therefore I'll close. You first say, does it need closure? Is this the right time for closure? It's the right time. What should I close it with? Okay, so that is decision making on device versus surgery. So when you ask that, now there are two, as you know, there are two types of devices, muscular and membranous. This is a muscular VSD occluder. How do you choose the device size? Now see in this, the leading disc, that is the one here, this one is 4 millimeters larger, this disc is 3 millimeters larger than this weight. Oh, this is the weight. How do you choose the device size in a muscular VSD? How do you choose which size to put in? Made of nitinol with Dacron mesh. What is the method of choosing device size? Why everyone struggling with this question? VSD opening on RVLV and then what size? Let's say the VSD opening not for muscular. Okay, listen, muscular will always be far from aorta. The distance from aorta doesn't determine. So what size do you use? Let us say the VSD opening is 8. On what? On echo. What size device will you use? If the VSD, if you measure it as 8, you're going to use something 1 to 2 millimeters larger than the largest size of the VSD as determined by TEE and angiography. Please remember this point. The largest size, you don't take it in systole when it's squeezed down. You've got to take the largest size of the VSD as you determine by TEE and on Angio, and then choose a device 1 to 2 millimeters larger than that largest size. So you reduce your risks of embolization. So if your largest size is 8 mm, then you can choose a 10 millimeter device. Okay, all clear on that? On choosing a device size. Next question, what device is this? What is the size of the waist? I put these questions in because we all know, okay, device thing, but now you all have to look in detail at every device, at the product notes from the manufacturer. So that's right, this is a membranous, perimembranous device. It's an eccentric perimembranous device. right? The RV and LV discs are offset. What is the size of the waist? So this is the one disc, right? This is one disc. In between the two, you have a waist, right? Obviously, that waist has to be very thick, very thin, because it's in the. So what is that size of the waist? And if you all don't know, you're going to go today into the cath lab and open that manufactured thing and read about the device in detail, right? Anyone? Size of that waist is 1.5 millimeters, okay? It's a very narrow waist, and the RV and LV discs are offset so that you can accommodate the normal apical displacement of the tricuspid valve as well as not impinge into the aortic valve. Okay, so that's your perimembranous device. Okay, so we said that once you decide that a patient needs VSD closure, you can decide on device versus surgical. So what are the criteria for saying this patient can have device closure? Which kind of patient? Okay, what was the question, ma'am? Please repeat. Oh, you wanted this repeated? This, you see, this one, the waist between your LV and RV disc, there's a little waist. Remember, like your ASD, you've got a LV disc, RV disc, and the waist. The waist is the size of your ASD. Here, between connecting these two, it's a very narrow waist. The size is very thin, 1.5 millimeters, because your membranous septum is very thin. Right? You can't have a very wide waist there. So just look at your device today and look at all these different measurements on it. Okay. So what are your criteria for transcatheter VSD closure? Which patients are suitable for VSD device? Okay. So rims, distance from aortic valve 4 mm. Anything else? So what about weight? Could you do a device in a 2 kilo baby? Right? So there are some weight cutoff. Now, ideally, more than 10 kilos, because you have wires, you can have arrhythmias. Now, if you read the National Committee guidelines, they actually say 15 kilos. So, you can at least know both these answers. So I think nowadays over 10 kilos, 8 to 10 kilos also you can do it. People that number is coming lower and lower and lower. So I'm sure there are centers that do it even at 5, 6 kilos who are very good with it. Second is it should be a moderate, right, size, typically not small for sure, and large ones are a little more dicey to do. If it's membranous, you need at least 2 millimeters of aortic rim because you don't want it going onto the aortic valve. Contraindication certainly would be if you have aortic regurg or cusp prolapse, LV to RH shunt, and therefore subpulmonic VSDs, where it's obviously too close to the aortic valve. Okay, all clear on that? Yes, and rims your right. Oh, the transmission from program second. The rims your right because in muscular, like if it's too close to the apex and there's no rim, it gets stuck. So you do need enough of the rim around it, but not too much of it. Now I will end with this. What is this procedure? This is not something you would see every day. Some centers may be doing it, some not. What is this procedure? Anyone? Bonus question, and then I'll let you go and have breakfast. Okay, it's a VSD device closure. The route, how have they done it? Look at the wire. It's going from RV to LV. Look at D. Right? So you're seeing on echo, then there's a wire going here, and it's going from the RV to LV, and they're putting it in, right? So this is, it's actually a muscular VSD device, but this is actually a hybrid technique. It's called the off-pump VSD closure. You do it in the operating room, but you're doing it off-pump, and you're deploying the VSD device closure through the chest itself. So this is one way you can do it in small babies so you're able to do it off bypass, but you're not taking to the cath lab with all the risks of it. So this is a hybrid technique where both the surgeon as well as the cardiologist do it together. The off-pump VSD closure. So I can send you some papers. We did a bunch of these pieces at NS, so I can send you some papers on that. So there are a lot of now kind of hybrid techniques that are there and this is one of the hybrid techniques for sicker babies, smaller babies with VSDs. You can extubate very quickly because you don't have all the issues of cardiopulmonary bypass, but you do have a little bit of the stenotomy still there. Okay, so I think I shall end with this, and Kunika, you can stop recording.
Yeah, sure.
I shall end with this, and